Secretary, I think you can share.
Yeah. You can see the.
Yes, we can see the screen.
Okay. So you tell me, inshallah, when we are ready to start.
We are ready. I think we can start.
Okay. Assalamu alaikum once again. Inshallah, in the next maybe 1 hour, 1.5 hours, we'll go through some quick ECG examples. I wish we had the opportunity of discussing the details so that instead of cramming, you understand and this concept remains with you. But I totally understand you guys, you are preparing for an exam. And of course, I wish you all the best in your exam. And inshallah, soon you will join us in the career and we'll see you in the corridors of the various hospitals as interns, MOs, and so on and so forth. So what I'll do is I quickly remind you, I suppose obviously you guys, your basics are good. So this is just a quick reminder. The first few slides is just a quick reminder. And thereafter we'll go through ACS ischemia, because that's very important, ischemia and infarct. We'll look at chamber enlargements. We'll look at some arrhythmias. We'll look at bundle branch blocks, AV blocks, and potassium abnormalities and pericarditis and apace rhythm. I think that will be more than enough. I'm not very sure if they will go outside that. And if you get the concept of these basic ones, I think the rest will be an add-on. So just a quick reminder, ECG as a tracing of the electric activity of the heart. We usually have, the one which we usually use commonly is called the standard 12-lead ECG. Why it's called 12-lead is because there are 6 limb leads and 6 chest leads. The 6 limb leads are divided into bipolar and unipolar. So lead 1, 2, 3, which is written in Roman number, it's usually bipolar. And this is where they usually place. One is in the right arm, one is in the left arm, and one is in the left foot. The positives are mostly, 2 of them are in the left foot and one is in the left arm. As far as chest leads is concerned, there's an echo. Is it coming from my side? I don't know.
No, it's not from your side.
Okay. You can hear me clearly, yeah?
Yes, we can.
So the chest leads are placed, and please make sure you learn where they are placed, because sometimes it's good, especially as an intern, now that you guys are becoming interns. Of course, not all facilities in Kenya have ECG. A large number of them, they really lack it. There are initiatives by different groups to try to equip hospitals with ECG. But this is something I would really urge all of you guys to learn. Don't pose it, just don't learn cesarean section and you are excited. I know you want to do CAs and surgeries, but learn some of these basics, because later on you may never know where you will learn to get employment. And ECG is a very important tool in the emergency field. So the V1, V2, V3, V4, V5, V6, this is how they are placed. Usually where my arrow is the angle of Lewy. The angle, the intercostal space below it is second. You start from there, second, third, fourth. Fourth on the right, you put your lead 1. Fourth on the left, you put your lead 2. V2. And then V4 is the point of maximal impulse, where you are palpating the apex, and usually is the mid-clavicular line. And then between the 2, you put your 3. Then you can put your 5 and 6 horizontal to V4 and V5. I mean to V4. So those are the 12 leads. I'll go back. This is lead 1, 2, 3. And then you have got 4, 5, 6, which is basically the chest leads. Then we have got AVR, AVL, AVF. And as you can see, the A is usually a small letter. It's augmented because what it generates an average electricity of the two limb leads. For example, AVL is found here. AVR is here. Sorry, is somewhere here. And then AVF is at the foot. But they usually measure the average vector of these leads. And that's why they are considered as unipolar. They are not bipolar. Now, in terms of anatomy, of course, not all waves must always be there, but basically, it usually starts with a P wave. Then we have got the QRS complex. We just call it complex because it's not a must you have a Q. It's not a must you have an R. It's not a must you have an S. You can have QS, you can have RS, you can have QR, etc, etc. So that's why we call it the QRS complex. Then we have the T wave. U wave is not a must to be there, especially seen in the young people, and as you'll see later in hypokalemia. The P wave is the one that tells us atrial activation. Once the atrium has been activated, there is a waiting period here, which is called the PR segment. This is where your His bundle, your AV node are all found. Then the electricity is transmitted to the ventricles. The ventricles contract very fast. As you can see, the wave is larger than the P wave because of the bulk of the muscles of the ventricles. Then from there, we have another isoelectric line, which is called the ST segment, and then comes the T wave. So that QRST, this region represents the ventricle, while the P wave represents the atrium. In terms of anatomy, there is a horizontal axis, which is usually represented by time. Then there's a vertical axis, which represents voltage. And most of the ECGs usually is 25 millimeters per second. So based on that mathematics, if 25 millimeters, which is 25 small boxes, equals to 1 second, how many small boxes represent, or what amount of small boxes represent time? That's how this figure of 0.2 and 0.04 comes. This is very important later on when you're calculating intervals, the PR interval, the QRS duration, the QT interval, all those things. And it's a very important thing you need to learn, so that later on, as we'll see some of the arrhythmias, you'll find the QRS complex is wide, the PR interval is prolonged, the QT interval is prolonged, so on and so forth. And then in the normal layout, when you open an ECG, especially when it's printed on an A4 paper, this is how it looks like. It's arranged so that you have the limb leads here, then followed by the augmented, which is also part of the limb leads, then the chest leads on this side. And that's why we call it 12-lead ECG, because it's 1 times 3 times 4. Then at the bottom here, which is not shown, we have what we call the rhythm strip, which is very, very important, because most of the calculations like the rate, the rhythm, whether it's sinus and so on and so forth, is usually done in the rhythm lead. And usually, although people, most of them, they use V1, some use V5, but the most common used is lead 2, because it's the only lead that is parallel to the electric flow of the heart. And it gives you a better picture when you want to look at P waves, when you want to look at the relationship between P and QRS. Sorry, when you want to look at the rhythm, so on and so forth, you use the rhythm strip. So whenever you open the ECG, this is how it's laid down. And as we'll see in the ischemia and infarction slide, each of these leads represent a certain area of the heart. For example, V1, V2, they are called contiguous lead because they look at one part of the heart. V3, V4 the same, V5, V6 same, 2, 3, and AVF the same. We'll see this in the subsequent slide. This is just an introduction to and a reminder of basically the anatomy of ECG. And in terms of approach, you use the rate rhythm axis. The rate, obviously, you know how to calculate it very easily, and use the rhythm strip. That's the one that will give you a very good rate calculation. You can count the number of big R boxes between, the number of big boxes between 2 R waves, and you divide that figure by 300. That's one way. You can also count the number of small boxes between 2 R waves and divide that by 1500. That's a second way. The third way, if you're in a hurry, for example, like in an exam setting very fast, and you have a rhythm strip below, and it's a 12-lead ECG printed on an A4 paper, just count the number of QRS complexes falling in that strip from one corner to another in the rhythm strip, and you multiply by that by 6. The same method is what you use to calculate if a patient has an irregular heart rhythm. So if the rhythm is irregular, you use the same method. You just count the number of QRS complexes falling in the we'll see in the subsequent ECGs, then you multiply by that by 6. Rhythm, from the previous talks, we have said there are only 3 rules. Rule number 1, there must be P preceding Q wave. 2, every P, the ratio is 1 to 1. 1 P, 1 QRS. 1 P, 1 QRS. And 3, the P wave must be upright. Upright means it's above the isoelectric line. If you fulfill those 3 criteria, then you have sinus rhythm. Anything outside that is called arrhythmia. Axis, you only look at 2 leads, lead 1 and AVF. If both of them are looking up, you have a normal axis. If lead 1 is looking down, you have right axis. If AVF is looking down, you may, I'm using the word may, you may have left axis. And to confirm, you look at lead 2. Why? Because lead 2, AVF, and lead 3 are called inferior leads. They are neighbors. So if there's an abnormality in one lead and you want to confirm, always look at the neighboring lead. So that if both lead 2 and AVF are looking down, then you have confirmed you have inferior axis. Left axis deviation. Then from there, you go to the individual waves, P wave, PR interval, PR segment, so on and so forth. And now we'll go to the main topics. That was just a brief introduction, a reminder of the various components of ECG, just a quick reminder on how you approach. Now we'll start with ACS and ischemia. ACS stands for acute coronary syndrome. I know this is not a topic of ACS, but I just want to remind you this. Let me go back, yes. So when a patient comes to you in accident emergency, the patient has got chest pain suggestive of angina, which I'm sure by now you all know the characteristics of angina. And the patient has got risk factor, you can say, I suspect acute coronary syndrome. That's the word you use. You don't say MI, you don't say heart attack, you don't say this. You just say, this patient has angina and I suspect acute coronary syndrome. You start there. The next thing, you do electrocardiogram. And that's why maybe when God gives us the chance, we'll discuss ACS in details. It's a golden rule that immediately the patient comes to a medical facility, he or she has chest pain, the first thing you do is an ECG. And the ECG will give you two answers. Is there ST elevation or not? If there is ST elevation, then you say, I have a patient with ST elevation, acute coronary syndrome. I have not used the word STEMI, if you note. So the first diagnosis is acute coronary syndrome. You do your ECG, then you say, I have an ST segment elevation, acute coronary syndrome. Then you do your troponins, which are called the cardiac enzymes. We don't use CKMB and these days as such. The most important enzyme right now is troponin, troponin I or troponin T, depending on your laboratory. So if you have done your cardiac marker, which is the troponin, if it is positive and you have ST segment elevation, then now you can say STEMI. I hope you're getting the difference. You can only use the letter MI, myocardial infarction, if there is elevated cardiac enzymes. Otherwise, you use the word acute coronary syndrome. Then on the other hand, you have non-ST segment acute coronary syndrome. If in the non-ST, the patient's cardiac troponin is high, then you call it NSTEMI. Are not at it, and there's no ST segment elevation, but the patient has got this patient has unstable angina. Now we begin. What do you mean by the ST segment? And the area where we are interested in,
which is defined as a new ST elevation.
sorry, let me just go back. So Kidogo, sorry, I'm mixing the slides. Yeah, so the area we are talking about is here. This is the ST segment. Is the area between where the S wave is until the T begins, this area. It's usually isoelectric. It's a flat line. If it is above that flat line, we call it ST elevation. If it is below that line, we call it ST depression. That's the most important thing. These cutoffs of 0.2 millimeters, those are details. And these are things you learn with time and experience. But the most important thing is concentrate on this region. If you want to rule out or rule in ischemia and MI and all that, you concentrate there. And this is the evolution of ST segment myocardial effusion. The first thing that happens is the T waves goes up, then there is T wave inversion. These are something you can read in your books. We'll go now to the real things. The other concept I want to discuss is, sorry, there was a bit of a recording in the background. That's why you're hearing that. Now, the most important thing is a concept called reciprocal changes. When you have an ST segment elevation, sorry. When you have an ST segment elevation in an area, sorry. When you have an ST segment elevation in one region, the opposite side, there is ST segment depression, and this is what you call reciprocal changes. So we'll see later on, for example, if you have lateral ST segment elevation, the inferior leads will show ST depression, and those are called reciprocal changes. The other important thing before we go into the respective areas is something called territories. Now, this ECG, if you remember the earlier slide which I showed you, V1, V2, V3, V4, V5, V6 is this blue line. Lead 1, 2, 3, lead 2, 3 AVF is this green one. Lead 1 and AVL is pink. And each one represents a particular artery. Okay, so that later on you will hear somebody saying, this patient's LAD is occluded. You wonder, how did he know? Kumbe, all they just looked at is V2, V1, V2, V3, and they found ST segment elevation. And that one looks at the LAD territory. That is left anterior descending artery. The left circumflex artery is usually represented by lead 1 and AVL, and RCA, which is an inferior, supplies the inferior part of the heart, is usually represented by lead 2, lead 3, and AVF. We'll see all of them one by one examples. Don't worry about it.
Okay. So subsequently.
So this is what we call anatomic location. V1, V2 is called septal. V3, V4 is called anterior. V5, V6 is called lateral. And also lead 1 and AVL, lead 2, lead 3, and AVF are called inferior leads. Now we'll see the respective, all the MIs one by one, and I will give you examples. The first one we are starting is septal MI. Septal MI, septal ST segment elevation. I have to be very specific. You can only use MI if there is troponin elevation. So septal ST segment elevation is usually represented by lead V1 and V2. And it usually represents proximal left anterior descending artery. That's what it represents. And it's a very important part because that is the beginning of usually LAD, and it sometimes covers a large territory. It's very rare sometimes to find septal ST segment elevation on its own. But just remember, if V1 and V2 you see ST segment elevation, I'll show you an ECG example, then you are talking of septal ST segment elevation. If the patient's troponin is high, then you can say septal MI. And this is how it looks like in the ECG. Now, when you look at this, this is lead V1, V2. Of course, you can see it's going all the way to V3, V4. And as you can see very clearly, you cannot miss ST segment elevation because this is our isoelectric line. Where my arrow is, if you can see it very clearly. And you can see the ST segment, this pattern is called QS, the T wave is here. And all this is elevated because it's supposed to be around this region. Okay, and this is very clear, nobody can miss this. So this is anterior because it's covering all the way from V1, V2, V3, V4 up to V4. This is what we can call it anteroseptal or anterior MI. Even if you say anterior ST segment elevation, or if you call it anteroseptal, why we call anteroseptal is because V3 and V4 are involved. Those are anterior leads. V1 and V2, as I've shown you earlier, are septal leads. So when you combine the two, you can call it anterior ST segment elevation. So I repeat, for the septal or for the anterior, you concentrate in V1, V2, V3, V4. It's very rare to have V1, V2 alone because that is the beginning of LAD. Of course, you can have only the septal branch, which supplies the interventricular septum, to be blocked. But generally speaking, by the time you have a disease there, there's another disease in the proximal LAD. And therefore, this kind of ECG is what you call anteroseptal ST segment elevation. The next one we are looking at anterior. Already we have seen the anterior. And this is a continuation, it's more or less like the other one. But specifically, if you want to specifically talk of anterior, you concentrate on V3 and V4. And this is very clear, as you can see, because this is where the ST segment is supposed to be. And from here all the way up there, that is markedly elevated. Why we are saying this more is anterior is because, as you can see, V1 is a little bit spared. But that notwithstanding, whenever you see V1, V2, V3, V4 involved, you can call it anteroseptal or you can call it anterior. Either way, you are correct. The most important thing is to identify that this patient has got an ST segment elevation. And why are we struggling to identify this condition? Because the way you treat is totally different. And that's why ECG has become the most important tool in the diagnosis and management of acute coronary syndrome. As I showed you in the earlier slide, if a patient you suspect chest pain, the diagnosis is acute coronary syndrome. You do an ECG, you see ST segment elevation. Therefore, this patient has ST elevated or ST segment elevation acute coronary syndrome. You don't even wait for enzymes. Those guys, you take them directly to cath lab. If you are in a place where there is no cath lab, you can't do angiography, you do something called thrombolysis. whether you thrombolize or whether you take patient to PCI, which is an angioplasty, that is called reperfusion strategy or reperfusion therapy. In other words, this patient, they need to be reperfused very fast, because what the ST segment elevation acute coronary syndrome is telling you is that that vessel is completely blocked. The mind we used to call it QMI. Those terminologies have been changed. These days, we only use ST segment elevation or non-ST segment elevation acute coronary syndrome. So ECG is the only tool that will tell you, take this patient to cath lab right now, or you have time, you can buy a bit of time. You can transfer the patient to Nairobi where they can do cath lab, so on and so forth. So that's why we are concentrating on this aspect. And I want you to identify in the leads. For anterior or anteroseptal is V1, V2, V3, V4. And we are looking at the ST segment. We are just looking for elevation. Right now, we are not talking of depression, because ST depression, the only time it will become important is when you have posterior MI, which I will show you an example. Then the next thing to go to is called the lateral leads. So we have covered anterior and anteroseptal. The next thing to go to is lateral. And lateral here, it represents left circumflex artery. Anterior and anteroseptal was LAD. So if somebody wants to talk about LAD occlusion, you go to V1 all the way to V4. Now V5, V6, AVL, and lead 1. So lead 1, lead AVL, V5, and V6. Although it's not very clear in V5, V6, it's very clear in AVL segment 11. Okay, this is the lateral leads. Lateral leads V1, lead 1 and AVL, they represent left circumflex artery. And now you remember that concept I told you called, it's called reciprocal changes. Now I'm unable to demonstrate this to you guys, but when you put your fist on your chest, which you guys can do, the lateral aspect is on the left side. Now the opposite of lateral is inferior. And you remember when I was talking the concept of reciprocal changes, you expect pressure 3 AVF leads are called inferior leads. They are looking at the lower part of the heart, and they are the opposite or the mirror of the lateral leads. Because the lateral lead has ST segment elevation, you will see ST segment depression in the inferior leads, and the opposite is true. If you have ST segment elevation in the inferior leads, you expect ST segment depression in the lateral leads, and that's what we call reciprocal changes. Another concept I want to introduce here is something called contiguous leads. If you have an ST segment elevation only in lead 1 and there's no change in AVL, you disregard it, because lead AVL and lead 1 are called contiguous leads. They are looking at the same part of the heart. The same thing in lead 2, 3, and AVF. If you see one change in AVF, the other two leads don't have, you disregard. The only time you take it seriously is if all those leads which are contiguous, looking at the same part of the heart, have got the same changes, whether ST depression or elevation. So here we discussed lateral ST segment elevation. So far we have discussed septal, anteroseptal, and now we are discussing lateral. For lateral, we are concentrating on left circumflex artery, and we are looking at lead 1 and AVL, and we are looking for ST segment elevation. When I see ST segment elevation in lead 1 and AVL, I'll automatically go to inferior leads to look for reciprocal changes. Okay. Now the last one is the inferior ST segment elevation. And because we are talking of inferior, I will immediately go to lead 2, lead 3, and AVF. And as you can see, there is clear ST segment elevation. There's even something else called QF, but we will not discuss right now. The important thing is this ST segment elevation, which is found in lead 2, 3, and AVF. This patient has an inferior ST segment elevation acute coronary syndrome. If I have done troponin and they're elevated, I can comfortably call this patient has inferior STEMI. Now, because there is ST segment elevation in the inferior leads, the opposite leads are the lateral leads, which is lead AVL and lead 1. And as you can see, there is ST segment depression is more prominent in AVL, but you can also see there's depression in lead 1. So I have a reciprocal changes in the lateral leads because they are the opposite leads to the inferior leads. Now, so far, I'll repeat again. When it comes to acute coronary syndrome or ischemic changes or infarct, you concentrate on the ST segment of the ECG, okay? And when you are looking at that, you look territorially. You look contiguously, meaning you look at the leads that are looking at the same path. If I'm interested in the anteriors, I look at V1, V2, V3, V4, and it denotes something or a problem with LAD. If I want to concentrate on LCX, I look at lead 1 AVL plus minus V5, V6, because they're also lateral leads. If I want to look at the RCA, the right coronary artery, which supplies the inferior part of the heart, I'll concentrate on lead 2, 3, and AVF. In lateral leads and inferior leads, they are mirror of each other. So when there's any ST elevation in one segment, you expect ST depression in the other, and that's called reciprocal changes. Now, this is a very important ECG, and I would like to draw your attention to two things. Number one, there is ST segment elevation in inferior leads. It's very clear. Lead 2, lead 3, and lead AVF. And our rhythm strip is here, which is lead 2 usually. There's a clear ST segment elevation. But there's something else. Because ST segment elevation in inferior leads will cause reciprocal change in AVL, I am also seeing ST depression in lead 1 and AVL. That's also clear. But there's something else I want to draw your attention to, and very important. How come we have ST depression in V1, V2, V3? This is a unique type of MI. We call it posterior ST segment elevation acute coronary syndrome. And it's something you must never, ever, ever miss. Why? Because the posterior part of the heart, we don't usually put leads. The tall of lead, standard leads, they usually finish at V6. But if you want to confirm ST segment elevation in the posterior part of the heart, you can do V7 and V8. Usually put at the back of the patient. And you'll see ST elevation in V1, V2, V3. So this is the concept of I was telling you. Because V7, V1, V2. So if I have posterior ST segment elevation, leads will be V1, V2. And I told you the mirror leads will usually have ST depression. And that's why you are seeing ST depression in V1, V2, V3. So I'll repeat, if you see ST depression in V1, V2, V3, please consider it as posterior acute coronary syndrome until proven otherwise. So when you see such kind of ST depression in V1, V2, please throw your eyes at the inferior leads. And therefore, if you have ST segment elevation in inferior leads, you have 100% assurance that this patient has got posterior ST segment elevation acute coronary syndrome, and you treat them urgently either with thrombolysis or with angioplasty. Okay? So in the subsequent ECGs, because we are finished with ACS and ischemia, I'll just give you examples. This is very clear. What can you see here? We have got ST segment elevations in V1, V2, V3, all the way to V4. This is a very massive, we call it massive anterior ST segment elevation acute coronary syndrome. And when you categorize, anterior STEMIs are very bad. This kind of patient, we usually keep them in ICU for 3-4 days because LAD, as you know, supplies a large part of the left ventricle. So you cannot compare anterior ST segment elevation with an inferior ST segment elevation. So usually anterior segment elevation are more important, but does not mean that all the others are not important. So this is very clear ST segment elevation, V1, V2, V3. You can comfortably say this patient has an anterior ST segment elevation. You start your usual clopidogrel, aspirin, you give Clexane, you give atorvastatin. If you can thrombolyze, fine. If you can't thrombolyze, send that patient to a place where cath lab can be done and the vessels are opened immediately. Okay? Yes, this is another ECG. As you can see, there is widespread ST segment elevation, but the most important thing is the ST segment elevation in the anterior leads. In this one, ST segment elevation is mostly found in the inferior leads. And because this is a lateral lead, lead AVL and lead 1, that's why there is ST segment depression. And as I told you, ST segment elevation in the inferior leads, please just throw your eyes at V1, V2 so that you don't miss posterior MI. This one is an example of the posterior MI. This patient has got ST segment depression in V1, V2, V3, but immediately you can see, sorry. Immediately you can see there is ST segment elevation in lead 2, 3, and AVF. And this is the kind of MI you should never miss. It's called posterior ST segment elevation. Again, another picture of a patient who has got inferior ST segment elevation. These are the same examples. So in summary, acute coronary syndrome and ischemia, you concentrate at the ST segment. You look for elevation or depression. The most important thing is elevation because that's a patient whose vessel is completely blocked. And you look territorially. V1, V2, V3 is anterior. Lead 1, AVL, V5, V6 is lateral. Lead 2, 3, and AVF are inferior. When you see an inferior ST segment elevation, you look for reciprocal changes in the lateral leads and the vice versa. When you see ST segment depression in V1, V2, please always consider posterior MI before you say this patient has got anterior ischemia. Now, if the patient has evolved, the first thing that happens is hyperacute T wave, then ST segment elevation, then T wave inversion. Finally, they develop what you call Q wave. And this one will tell you an old infarct. And when you look at this kind of patient, look at V1 and V2. From P wave directly, the thing comes down. Usually, you're supposed to see a small R. So this is a patient who has developed MI previously. And in fact, right now, even there is ST segment elevation in V2 and V3, and you can see T wave inversion. When you see this kind of thing, this is a patient who has already had MI before, but is also suffering another event. And therefore, you take the patient immediately to cath lab. In this ECG, the most important, I don't know if you can see very clearly, is Q waves in the inferior leads. Because you can see here there is Q wave, and this Q wave will become pathologic or important if it's especially bigger than or deeper than a third of the corresponding R wave. And when you see here, this is an R wave because it's coming is a positive wave after the Q wave, but the Q wave is bigger than the R wave. So this is Q wave. It's also in the inferior leads. That's lead 3, lead. You see two contiguous leads having the same change. This is a patient who had an old infarct. See in the ward round, a patient is asked, did you have an MI before? Then they tell you yes. You wonder how did this doctor know? Kumbe, they only looked at the region and they look for Q wave. If you have Q wave in V1, V2, V3, that's an old anterior infarct. If you have Q waves in 2, 3, and AVF, that is an old infarct in the inferior part of the heart. And if there's Q wave in V5, V6, AVL, and lead 1, that is an old lateral MI. That one you can comfortably actually use the word MI because it's infarcted. Q wave means that area is scarred, that muscle has died. And therefore, you can actually comfortably say lateral MI. You can actually comfortably say anterior MI. When you see Q waves, you can use the word MI. But unless you see Q wave or the troponin is elevated, you cannot use the letters MI. This is ECG changes in NSTEMI, non-ST segment elevation acute coronary syndrome. And they are non-specific changes. You can have T wave inversions. You can have ST segment depression, widespread, like in this case here you can see. Now the difference between this and ST segment elevation is this one does not localize the pathology. If you have ST segment depression in 1 and AVL, it does not mean that there is ischemia in the lateral wall. No, it's just telling you that there is an area in that part of the heart which is starved of oxygen, but the muscle is still alive, that it is partially blocked. And this is where you do your cardiac troponin, and you distinguish as NSTEMI or unstable angina. If the troponin is high and there are non-specific ST and T wave changes, and the troponin is high, you call it NSTEMI. But if there is no troponin elevated, but there is non-specific ST wave changes, you can still call it non-ST segment elevation acute coronary syndrome. If, however, there are specific changes like ST segment depression, T wave inversions, but the enzymes are normal, but the patient has a characteristic angina, then you call it unstable angina. and it's still considered as part of acute coronary syndrome. So this is the differential diagnosis of ST segment elevation, and it's not always MI. But you need to remember electrolytes, which you will see some ECG about it, hyperkalemia, left bundle branch block, you will see it. Early repolarization is an important point, especially in young men between the age of 20 to 30. You will see some ST segment elevation in V1, V2, V3, but characteristically those patients are healthy, they don't have chest pain. You have ruled out any other cardiac cause, and that's when you can call early repolarization. Ventricular hypertrophy is the cause of ST segment elevation. Arrhythmias, Brugada syndrome, ventricular tachycardia, we'll see all of them on one ECG examples. There's a condition called Takotsubo disease. It's quite common. They usually come characteristically with chest pain, ST segment elevation. You do troponin is high. You go to the cath lab, but the coronaries are clean. It's called Takotsubo disease. It happens mostly in a stressful environment. And then MI, you can have injury, inflammation, ischemia, and non-atherosclerotic vasospasmodic prismatal angina. And the mnemonic is elevation. I'll share with you the slides. You can go through them one by one. And that is the first part. We have finished acute coronary syndrome. I hope you'll be comfortable identifying what segment to look at, what territory to look at, what is ST segment elevation, what does it imply, and which artery is blocked, and what you are supposed to do. So in the OSCEs, it can come like this. You can be given a scenario. I don't know how your OSCEs are. You can be given a scenario, and they like inferior ST segment elevation for 3 reasons. Number 1, inferior ST segment elevation, patients usually present with bradycardia. So if you are told a patient chest pain, heart rate of around 40, you're given an ECG, always start with the inferior leads. Most likely this patient has ST segment elevation. That's the first reason. The second reason is that patients who have got inferior ST segment elevation, usually because the right ventricle is supplied by RCA, and RCA supplies the lower part of the heart. Now, there is an entity called RV infarct. Patients who have got MI in the right ventricle, there is a drug you should avoid completely, which is normally used in ST segment elevation, and that's nitrate. So a patient who is bradycardic, has got inferior ST segment elevation, most likely may have, and that's the trick you should look for, right ventricular infarct. And if there's a right ventricular infarct, you should never give that patient nitrate. You should never give that patient Lasix, because the right ventricle is preload dependent. And if you give nitrate, you're reducing preload and you are even worsening the condition. So for those 3 reasons, the most common ECG they like bringing is inferior ST segment elevation. Now, the second reason why they bring ST segment elevation is for you to identify very fast, because they call it time is muscle. The more you delay, the more that patient will die and the more the patient will complicate. And the other reason why I told you is ST segment elevation, the management is different. You say you open that artery by whatever means, whether you use a clot buster like thrombolysis or whether you use angioplasty. Okay, so concentrate on the ST segment region. Look at the ST segment elevation, which territory. If you see ST segment elevation alone in V1 and V2 is normal, disregard it. It must be shown in another contiguous lead. So they usually say in 2 contiguous leads. Okay, so the anterior leads, the anteroseptal, the lateral, and the inferior. This one now brings us next to chamber enlargement. This is very fast. We will not take much time of it. And we'll start with left ventricular. The most important thing to remember are the causes. Causes of left ventricular hypertrophy. The first one you should always start whenever you are asked for OSCE, because you can be asked 3 differential diagnoses of this abnormality. For example, you'll be given an ECG of a patient with left ventricular hypertrophy. Once you have said this criteria for LVH, you may be asked the causes of this. And always start with common things. Don't start with or coarctation of the aorta. Start with hypertension, because it's the commonest. Common things happen more common. Hypertension, aortic stenosis, aortic regurgitation, anything that will load the ventricle, anything that will block the ventricle, anything that will put a pressure on the ventricle will cause left ventricular hypertrophy. There are very, very many criteria for diagnosing left ventricular hypertrophy. The common one, which is usually used, is what I'll share with you because of time. And that's the thing you really need to look very critically at this ECG, so that when you have this kind of ECG in front of you, you can diagnose LVH very, very, very easily. The most common one which is used is called Sokolov criteria. You don't need to name to know the name, but that's the commonest one. There are very many other criteria, Lyon's criteria, AVR criteria, AVL criteria, but the one which is mostly used is called Sokolov criteria, and that's the one I will share with you in this slide. The most important things you need to look at is quickly, especially in an exam setting, when you see these waves in Indiana, you see V5 and V4, they are almost merging into each other. V3, V2, yani you can't distinguish the wave from here and the wave from here, zimeingiana, zinapitana, crisscrossing all over. Most likely you have got left ventricular hypertrophy. But for purposes of learning, you only look at two leads. You remember, I think, did we discuss? I can't remember. But when you are looking at the atrium, as you will see, you look at the P wave. But because here we are talking of the ventricle, you look at the QRS complex. And the two leads you look at is V1 and V5 or V6, whichever is taller. Why? Because V1 is sitting right on top of the right ventricle. V5 is sitting at the apex of the ventricle, left ventricle. So when there is a chamber enlargement, left ventricle or right ventricle, there will be a pull and push of electricity. To give you an example, when you have got a deep S wave in V1 and a very tall R wave in V5, that is already LVH. And usually I tell students the best way to remember LVH, the easiest way is an exaggeration of a normal ECG. A normal ECG, the S is deeper in V1. But in LVH, the S even becomes deeper. In a normal ECG, R is tall in V5. In LVH, it becomes taller. So exaggeration of a normal ECG until proven otherwise is LVH. That's the best way to remember. I hope that is very clear. But if somebody wants to know the criteria, you just say S in V1 plus R in V5 if it's more than 35 millimeters. You remember we said one large box is 5 millimeters. So you count how many large boxes are here. 1, 2, 3, 4, 5. That is already 25. Then if you add this one of V5, I don't know even where it's ending because it's merging into V4, you are very sure that you have got more than 35 millimeters. Those are 7 large boxes. That is S in V1 plus R in V5 or V6, whichever is taller. But in an exam setting where you don't have time to calculate, just remember one thing. If the ECG looks exaggerated, the waves in Indiana one by one, they are merging, and you are looking at V1, the S is becoming too deep, while the R in V5 is becoming too tall, you have LVH. And that's the end of left ventricular hypertrophy. The thing you need to remember is the causes and identify LVH in ECG. Now there's something called LV strain pattern. When you look at V5, V6, lead 1, AVL, any lead that is looking at the left ventricle, specifically the lateral and the inferior and the anterior, lateral and the inferior, you'll see ST segmentation and T wave inversion. That is LVH. Okay, let's go to right ventricle. Again, you always concentrate on V1, V5 because we are dealing with the ventricles. Again, there is pull and push. Now, in a normal ECG, you should not see an R wave in V1, a tall R wave. Usually the S is bigger than R. In a normal ECG, you should not, with capital letter, see an S wave in V5 or V6. If you see V5, V6 are having an S wave, and there is a tall R wave, or the R is bigger than the S wave in lead V1, then you have RVH. Another way to confirm it, you look for right axis deviation. And you remember we said if lead 1 is negative, you have right axis deviation. So if you have right axis deviation, R is bigger than S in V1, S is bigger or there is S in V5, when you have those 3 criteria, you have right ventricular hypertrophy. And the causes is anything to do with the lungs. Just use the word P, pulmonary hypertension, pulmonary embolism, cor pulmonale, you know, pulmonary stenosis, etc., etc., etc. You concentrate on the lung. You just ask yourself, what could be standing in front of the right ventricle so that it cannot pump blood enough so that the blood is going back to an extent it's making the wall very thick. From pulmonary stenosis all the way to pulmonary hypertension, pulmonary embolism, mitral stenosis, because there will be reflux of blood into the left atrium, backward, pulmonary hypertension, etc., etc. So I'll repeat the RVH. I'll repeat RVH and LVH. I will look only at V1, V5. In RVH, V1, the R is bigger than S, and in V5, there is an S. Ideally, there should not be an S in V5. If you see S in V5 or V6, there is a problem. I'll throw my eyes immediately at V1. In V1, I'm seeing a big R. Okay, what is the axis is right? I have a right axis deviation. I have a tall R wave in V1. I have an S in V5. I have confirmed this patient has right ventricular hypertrophy. Then I ask myself, what are the differential diagnoses or the cause of right ventricular hypertrophy? Next, atrial enlargement. Now in the atria, you concentrate on P wave. Just the way we concentrated on V1, V5 in the QRS complex for the ventricles, here we are concentrating on lead V1 and lead 2. And we are concentrating on the P wave. Now, normally, the P in lead 2 is 2 by 2, 2 small boxes up, 2 small boxes horizontal. In V1, there is biphasic. The negative and the positive are almost the same. In right atrial enlargement, the P than 2 small boxes. While in V1, the first positive becomes more prominent. In left atrial enlargement, the P wave in lead 2 becomes broad and notched. It becomes broad and notched. While in V1, the negative deflection, which was representing the left atrium, becomes more prominent. Now, let me show you examples. For the left atrial enlargement in V1, the negative deflection, which is the biphasic negative part, becomes more prominent. While in lead 2, the P wave becomes broad.
Excuse Dr. Hassan. Dr. Hassan, are you still with us? We can't hear you.
Hello?
Yeah, Dr. Hassan, we can hear you. You dropped.
I dropped at what point?
When you were explaining the P mitrale. Or you can even start
Yes.
from that enlargement just now. Yeah, it's okay, no problem.
Yeah. So I was telling you, so left atrial enlargement, you concentrate at V1 and lead 2. And in V1, the negative part is usually exaggerated. And in lead 2, the P mitrale becomes, the P wave becomes broad and notched. And most of the causes is caused by the mitral valve, hence the name P mitrale. The right atrial enlargement, again, you concentrate in lead V1 and lead 2. And usually, because it's biphasic, as you can see, the positive part becomes more exaggerated. And in lead 2, the P wave becomes tall and peaked. And because most of the causes is related to the pulmonary system, that's why it's called P pulmonale. So everything we have mentioned in right ventricular hypertrophy here, everything I mentioned here will also cause right atrial enlargement. And we are done with chamber enlargement. I'll summarize. For the ventricles, concentrate on V1 and V5. And in left ventricular hypertrophy is exaggeration of a normal ECG. The S in V1 becomes deeper, the R in V5 becomes taller. In the right ventricular hypertrophy, the R becomes taller than S wave in V1, while in V5 and V6, you will see an S wave which should not be there. In addition to that, you have right axis deviation. For the atria, you look at V1 and lead 2, and in right atrial enlargement, the P wave in lead 2 becomes tall, while the positive aspect of V1 becomes more exaggerated. The left atrial enlargement is the opposite. The negative deflection of V1 becomes more prominent, and the P wave in the lead 2 becomes broad and notched, and we call it P mitrale. The next thing we go to is bundle branch blocks. This may also be, it may come in the sometimes the OSCE, so that you'll be able to identify. And I'll concentrate. There are 4 types. There's left bundle branch block, right bundle branch block, and what you call the HEMIBLOCKS. There is this thing we used to call it William Marrow. And as you can see, anything to do with the ventricles, we only concentrate on V1 and V5 or V6, whichever is more prominent, whether it's hypertrophy, whether it's bundle branch, and so on and so forth. Now, in left bundle branch block, what it means that the left bundle is blocked. And therefore, electricity travels first in the right bundle, then it comes back to stimulate the left side of the heart, basically the left bundle side. And this is denoted in the ECG. So when you see a QRS that is notched, first of all, the first criteria for bundle branch blocks is that the QRS is wide. And you remember we talked of what you call QRS duration. So usually this QRS, if it is wide, it means this problem is at the ventricular level because of the delay, because of the block. Number 2, you will have a notched QRS complex in V5 or V6. And the notch is because we stimulate the right side, and then when we are about to close the chapter and say, oh, the ventricle have contracted, we remember about that the left bundle was blocked. So the right bundle sends electricity back to the left ventricle, the area which is supposed to be supplied by the left bundle branch. And that's why you will see this notch, hence the delay. So the QRS is wide, more than 120 milliseconds. It means it's bigger than or wider than 3 small boxes. Number 2, you will see a notched. The QRS here is notched. And that's why the M pattern. And you remember something called William Marrow. So William is for left bundle branch block. William, it's W because V1 is a notched S wave, while in the M is represented by a notched QRS in V6. So it's the opposite. Here, what is notched is the S wave. Here, what is notched is the QRS. And sorry, the R wave. So because of the notch in V1, we call it W, hence the first letter William. The last letter, which is M, is Marrow because this looks like letter M, the notch in V6. So as this ECG is represented here very clearly, you can't see the notch in V1, but the notch in V5 and V6 is very clear. Okay, where my arrow is. Okay, so I repeat, number 1, QRS complex is wide. Number 2, you will have a notched S wave in V1 and a notched R wave in V6. Finally, again, still in the left bundle branch block, usually the T wave is opposite the QRS. If the QRS is down, the T wave is up. If the QRS is up, the T wave is down. So remember, 1, a broad QRS complex. 2, a notched R wave in V6. 3, a notched S wave in V5, and a T wave that is opposite to the whatever of the QRS. That gives you a left bundle branch block. The notching, even if you don't see in V5, V6, you also look at the lateral leads. I always tell you in ECG, there's what you call contiguous leads. And you can see lead 1 and AVL are lateral. They are looking at the same area as V5. And here it's clearly notched. Okay, and now left bundle branch block is very, very, very important, because if a patient didn't have left bundle branch block, he comes to the accident emergency with chest pain, and the ECG shows left bundle branch block, you treat it as ST segment elevation acute coronary syndrome until proven otherwise. Right bundle branch block is the opposite. This time, we have got a block in the right bundle. So electricity travels in the left bundle, the left ventricle is stimulated, then the electricity comes back to the right ventricle to stimulate. Again, the same thing, the delay here. So this time what you will see, this one we call it marrow. Why we call it marrow is because the first letter M happens in V1 and it looks like M. Again, the same logic, it's notched. So a notched R wave in V1, which is the opposite of what was happening in left bundle branch block, okay? And then a W pattern, which is seen in V5. Now this W may be a bit tricky, but when you look at very clearly, sometimes you can even magnify the S wave here, it's usually notched, okay? And now, when you see a deep, broad S wave in V6 and a notched R wave in V1, again, the QRS is wide, that is right bundle branch block. Right bundle branch block is also equally important, but when you compare the two, left bundle branch block is more important in terms of ischemia and infarct, because it's basically telling you that this patient has had some kind of infarct to the extent that even the bundles are lacking blood supply, hence lack of electricity to supply to that particular chamber. Now this one, I really don't want to dwell so much. We call them HEMIBLOCKS or fascicular blocks. Why we call them fascicular blocks is this time the block is at the branch of the left bundle branch. Because remember, left bundle branch, immediately it becomes out when they separate into right bundle and left bundle. The left bundle divides into two, anterior fascicle and posterior fascicle. The anterior fascicle supplies the anterior part of the heart, while the posterior fascicles supplies the posterior part of the left ventricle. Here we are talking of the left ventricle. And when there is a block in either of the fascicles, you will see this kind of picture. It's very, very easy to remember. You will go through this ECG, but one thing I just want you to remember quickly is left anterior fascicular block, you always get left axis deviation to start with. Left posterior fascicular block, you will get right axis deviation. You remember I told you when lead 1 is negative, that's right axis deviation. When AVF and lead 2 are negative, that's left axis deviation. So that's the first difference between the two. Left anterior fascicular block, left axis. Left posterior fascicular block, right axis. The second difference is in the left anterior fascicular block, the pattern you get in the lateral leads, that is lead 1 and AVL, is a small Q and a tall R. In left anterior fascicular block, you get the opposite in the inferior leads, a small R and a tall S or a deep S. The same thing happens, but in the opposite. Instead of RS in the inferior leads, this time you get it in the lateral leads in the left posterior fascicular block. So this one I really don't want to dwell. It's very, very easy. It's actually more straightforward than left bundle branch blocks. But just remember that the one which is important for you at your level is left bundle branch block. This is something you should not miss. One, I told you because it's STEMI equivalent. Two, I forgot to mention that one of the most important management for left bundle branch block is a device therapy called CRT, cardiac resynchronization therapy, because patients who have long-standing left bundle branch block can come with heart failure. You look for coronaries, they are clean. You look for any other cause, nothing. Kumbe, the patient's heart failure is because of the bundle branch block. How do you treat? A device therapy. What do you call it? CRT, cardiac resynchronization therapy. It's a special type of pacemaker with 3 wires. That's why LBB is more important for you guys than RBB or fascicular blocks. Finally, second last part, we are going to arrhythmias, and I'll not go into all the arrhythmias. The important thing is what I want to go through very fast. Atrial fibrillation is straightforward. Nobody will ever miss it. There are only two, three things you need to remember in atrial fibrillations. Always look at the rhythm lead, HAPA, lead 2. Ask yourself, are you seeing a visible P wave? No. Is the rhythm regular? No. That is atrial fibrillation until proven otherwise, period. Now, what is the importance of atrial fibrillation in OSCE? Identifying is very easy. You just look at here, this thing is irregular and there is no P wave. Why is it important? Three things. Number one, you may be asked, a patient who has got atrial fibrillation, what is the most important thing or how do you approach? Regardless of whatever you forget, don't forget one thing. You just say, I will evaluate the patient for stroke, because that's the most feared and most important complication. You may be asked, how do you evaluate? You'll say there are various risk scores, and one of the commonest risk scores which you use is called CHARS 2 VASC score. So you'll say, I'll risk stratify the patient, whether he or she will benefit from anticoagulation. And you'll use the various types of anticoagulants, which brings a new dimension. You need to know the various types of anticoagulants and the new drugs, which are almost replacing warfarin. They are called NOACs, novel oral anticoagulants or direct oral anticoagulants. Make sure you note it somewhere and read about it. The other thing you'll be asked about atrial fibrillation is, what else apart from stroke evaluation? The next thing is rhythm versus rate. Because most of these patients, usually their heart rate is very high, but not always. Like this ECG on the left side, we call it atrial fibrillation with slow ventricular rate. This one, atrial fibrillation with fast ventricular rate. As you can see, it's very fast. And this is the rate I was telling you. Like this patient, if you want to calculate the rate, you just say 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22. 22 times 6, 132 roughly. So the rate here is 132. Here, it's 1, 2, 3, 4, 5, 6. 6 times 6, 36. So this patient has atrial fibrillation, but with slow ventricular rate. This patient has got atrial fibrillation with fast ventricular rate. Why is it important in OSCE? I told you, first identify the rhythm. Number two, the risk associated with it. And the most important risk is stroke. And number three, how to evaluate for that patient. You'll say, I'll risk stratify the patient for stroke prevention or for stroke prophylaxis using anticoagulation and using certain risk factors, the most common one being CHARS 2 VASC score. So that if it's more than a certain figure in female, you give anticoagulant, and for male is 2. For female is usually 1. Atrial flutter. Now, the difference between atrial flutter and atrial fibrillation is that atrial flutter is more likely to be regular. However, if you have got atrial flutter with a block, it may not be regular. But as you can see, it's usually cleaner, unless the previous one, which was very chaotic. This one is usually saw-toothed. This, where my arrow is, these are P waves. And usually the conduction here is 2 to 1. 2 to 1 means the AV node will allow for every 2 contraction of the atria, it allows only 1 to pass to the ventricle. So if I calculate the rate here, and the rate I'm talking about is the ventricle, the ventricular rate, you still use the same thing, 1, 2, 3, you calculate. If I get 150, the atrial rate is 300 because the ratio is 2 to 1. Okay? So atrial flutter, the treatment, the approach is exactly the same as atrial fibrillation. You still risk stratify this patient, you treat them like atrial fibrillation, make sure that they don't get stroke. If their risk score is more than a certain value, you anticoagulate them. PVCs. PVCs are called premature ventricular complexes. They are also called ventricular ectopic beats. They are the same. It's the same thing. Now, how do you know this is a PVC? A normal QRS, a normal sinus rhythm, it has a P QRS T. Now, number one, it does not look like a normal QRS. That's criteria number one. Number two, there is no P wave in front of it. Number three, it is usually broader than QRS because it's coming from the ventricle. Number four, it comes earlier than the normal contraction. If I give you an example here, this is a normal QRS, this is a PVC. As you can see, it came earlier. That's why you use the word premature. Number five, the T wave is always opposite. If the QRS is looking up of the PVC, the T wave is opposite. Number four, is it 4 or 5? Number 5, the distance between the first QRS and the PVC and the distance between the next QRS it's usually twice. Yani this distance is twice, this distance, sorry, is twice the earlier distance. In other words, the distance between the PVC and the first QRS is usually half of the distance between the PVC and the next QRS. And you can name them in several ways. Like I will give you an example. This is called bigeminy. Why do you call bigeminy? It is QRS PVC, QRS PVC, QRS PVC. That's called bigeminy. This one is called trigeminy because it is in quadrigeminy. Sorry, it's one normal QRS, normal QRS, normal QRS, a PVC. So you usually name according to how many QRS complexes are there, including the PVC itself. If there are two normal QRS followed by a PVC, that's trigeminy. If there are 3 QRSs, then a PVC, that's quadrigeminy. If there are 2 PVCs following each other, that's called couplet, and so on and so forth. The important thing I want you to identify is to identify a PVC. As I told you, 1, it has no P in front of it. 2, it has a different morphology. It looks abnormal compared to the other QRS complexes. 3, it is usually broader. It has a wide QRS duration. 4, its T wave is opposite the QRS complex. 5, the distance before it is half the distance after it. And this is very important because when several PVCs come together, we call it sustained, non-sustained ventricular tachycardia. When now they become more than 10 or they run for more than 30 seconds, we call them ventricular tachycardia. That's why PVCs are very important. Bigeminy, trigeminy, quadrigeminy, this thing depends on the number of QRS before the PVC. If there are 2, they are trigeminy. If there are 3, quadrigeminy. If there's a QRS normal, PVC normal, like in this case, we call it bigeminy. Ventricular tachycardia is another important arrhythmia which you need to identify. Now, the ones which are very, very important for OSCE is atrial fibrillation, ventricular tachycardia. Why? Because this, as you know very well from ACLS and all these things, this is a malignant arrhythmia. This one can kill, it can cause cardiac arrest. There are different types of ventricular tachycardias. This is not the time to discuss it. The most important thing is, number 1, it's usually regular. The distance between this and this is constant, like that. Now, if the QRS, they all look the same, we call it monomorphic ventricular tachycardia. If there are different shapes and types, I will show you, like in this case, for example, you call it polymorphic ventricular tachycardia. You must identify ventricular tachycardia because the cause of cardiac arrest. Usually there's an underlying problem, and you need to identify, especially if you are giving a clinical history, if you are telling a 60-year-old patient come with chest pain, this is the rhythm identified, that is ventricular tachycardia. Don't look for anything else. How do you manage it? It depends on the vital signs or the stability of the patient, hemodynamic stability of the patient. If the patient is hemodynamically compromised and there is pulse, you cardiovert electrically. If the patient is hemodynamically unstable and the patient has no pulse, then you defibrillate. You remember something called pulseless VTAC. If the patient is hemodynamically stable, then you can manage with antiarrhythmics. You don't need to cardiovert or do anything else. This one you can all remember very well. Unlike this one, which is regular, this one is irregular and chaotic. And that's why we call it ventricular fibrillation. This one, there is no wasting time. This is ACLS. This patient, you defibrillate. Because this is a chaotic rhythm. It's a rhythm that does not perfuse. This patient will go into cardiac arrest, and this is a shockable rhythm. This one and pulseless VTAC, pulseless ventricular tachycardia, are called shockable rhythms in ACLS. If you see something like this in your OSCE, you just say this is ventricular fibrillation. You can even describe, you say this is an irregular, chaotic rhythm, most likely ventricular fibrillation. This patient, I will defibrillate. This one, we don't talk about stability, hemodynamic, story. This one, you defibrillate. This is the one you talk about stability and pulse and those kind of things. Okay? And those are the rhythms. The ones which are important is atrial fibrillation, PVC just for identification purpose, but ventricular tachycardia and ventricular fibrillation. Now, quickly, the blocks. AV block, first degree, AV block, I will not discuss it. We'll finish in the next 15 minutes. First degree AV block, I will not talk about it. This is basically a normal ECG. The only problem is the PR interval is prolonged. And PR interval, I remember I told you, it's from the beginning of P wave to the beginning of the P wave up to the beginning of the QRS complex. Normally, it's supposed to be one large one large box. If it's more than one large box, which is like 0.2 second, then you say prolonged PR interval. And since every P wave is followed by QRS, P wave, QRS, P wave, QRS, the only problem is prolonged PR interval, we call it first degree AV block. Actually, ideally, it's supposed to be called first degree AV delay rather than a block. But just for purpose of academics, just to know that it's characterized by a prolonged PR interval of more than 0.2 seconds. Otherwise, it's a normal ECG. This is an example of first degree AV block. As you can see, this is P wave, this is QRS. And it's starting from here all the way, it's crossing the large box. This is almost 1.5 large box. Otherwise, the ECG is normal. PQRS is regular. There is no any other abnormality. The only abnormality is prolonged PR interval. We call it first degree AV block. In the second degree AV block, we divide into two types. There is type 1 and type 2. We call them Mobitz AV block. So second degree AV block, another name is Mobitz AV block. Mobitz type 1 and type 2. The difference between Mobitz type 1 and type 2 is that in Mobitz type 1, what usually happens is that the PR keeps on prolonging until it's dropped. For example, here, this is the PR interval, is a bit short. This is longer than the previous one. Then finally, it's dropped. Here, there is no P wave. Then a new cycle begins. A small P, longest drop, that's what they call it. Now, one of the first way to discover in an exam setting is like this. Number one, first of all, the rhythm is irregular. Number two, you will find that there is clustering. They come close to each other, then all of a sudden there is a pause. They come close to each other, the distance between two R waves is getting prolonged until there is a drop. That is type 1, Mobitz type 1. Mobitz type 2, there is also a drop, but the difference between the two of them is that the PR interval is constant. Here there is no prolongation. But also just like the other one, it's also irregular. So just remember, one of the causes of an irregular pulse is an AV block, specifically type 2, Mobitz type 2. Second degree AV block is a cause of irregular heart rate. Because the other cause of irregular heart rate is atrial fibrillation. The second cause is second degree AV block. First degree and third degree, they don't cause irregular pulse. If you see irregular pulse and you suspect the patient has an AV block, you are dealing with second degree AV block. What will help you distinguish whether it's type 1, type 2 is the ECG. In type 1, the PR interval keeps on prolonging until there is no more P wave. While in type 2, there is still a drop, there is no QRS, the P wave after it, there is no QRS, but the PR interval is constant, like in this case. The PR is interval, here there is a drop. So there is P wave, but there is no transmission. Then another QRS comes. Another QRS comes. The PR interval is constant. Then there is a P wave here, it's not transmitted. There is another P wave here, it's not transmitted. Then we have a third P wave, which is transmitted. Okay? Now in third degree AV block, the most important thing, it's regular. Don't forget that. Because in an ECG setting, in an exam setting, you may have a problem distinguishing between complete heart block and third degree and second degree AV block. Look at this. This is a very regular ECG. This rate here is constant. But how will you know this is complete heart block? You will always see more P waves than QRSs. So that's how you'll distinguish. I hope this one helps. Let me go back to the second degree AV blocks. The heart rhythm here is irregular. But in third degree AV block, the heart rhythm is regular. Now, once you have found that the heart rhythm is regular and you see the rate is very slow, this is 1, 2, 3, 4, 5, 6, 7. 7 times 6, 42. So that's a low heart rate. But then all these things you are seeing here are P waves. When you see a lot of P waves compared to QRS complexes and it's regular, that is third degree AV block. Now, miscellaneous. We start with this first ECG. In this ECG, I know maybe you are not able to pick it and it's not an interactive session, but there's something that is very unique. There is ST segment elevation in V2, V3, V4, in inferior leads, in the lateral leads, everywhere basically. Lateral leads, inferior leads, V1, V2 is not territorial. Unlike in acute coronary syndrome, where you used to see ST segment elevation in a particular region, when you see widespread ST segment elevation in an ECG and the patient has got chest pain, the differential diagnosis is pericarditis. So widespread ST segment elevation with no reciprocal changes, that's not following any anatomy, it's pericarditis until proven otherwise. The last 3 ECGs is about potassium, the last 2 ECGs, and then we have got hyperkalemia and hypokalemia, because this is very important. Now, potassium can affect all the waves, from P wave all the way to T wave. But in hyperkalemia, the problem begins with the T wave. And that's very important. So when you see a tall T wave in a patient who is on dialysis, a patient who is taking ACE inhibitor, a patient who is anuric, a patient who is not passing urine, that is hyperkalemia until proven otherwise. So when you see tall, symmetrical, tented T waves, and they are everywhere, all the leads basically have it, it's hyperkalemia. Don't forget that you can have a tall symmetric T wave as a result of MI. Acute coronary syndrome in the early stage can cause tall peaked T waves, but that one it causes in those leads. If it's anterior, anterior. If it's inferior, inferior. But if you're seeing T waves everywhere, that is hyperkalemia. As you can also see in this ECG, there is T wave. The T wave is taller than the corresponding QRS and is in all the leads, whether it's lead 1, 2, 3, AVF, VR, it doesn't make a difference. So that tells you that this is hyperkalemia. Of course, there are levels for hyperkalemia. That one I will leave it to you to go through it, how to manage it. This is very important. All these things we are discussing to identify the problem, but the most important thing, don't forget the exam doesn't finish there. The question is the differential diagnosis. How do you approach this patient? How do you investigate? You'll say you'll do electrolytes, serum, potassium, and then how do you manage it? And then depending on the level, I know you know how to manage hyperkalemia depending on the level. But the most important thing is if hyperkalemia is causing ECG changes, you give calcium gluconate. If there is no ECG changes, but the potassium is high, it's now when you do your other things, your insulin, your salbutamol, I don't know what, Ventolin, But the catch point here is there ECG changes because of potassium? Yes, give calcium. Okay. Hypokalemia, the most important thing is 2 things. One is U wave, and U wave usually comes after the T wave. It looks like a small P wave, and then you'll find that between the T and the P, there's a small bump. When you see that, ask yourself, could this be hypokalemia? But don't forget, it can be a normal finding in young people. Of course, ECG, as I have already told you, we always interpret in the context of history, clinical exam, and so on and so forth. And usually hypokalemia is a very good ground for bringing ventricular tachycardias and so on and so forth. That's why in ACLS protocol, I'm sure you have gone through the training, you always talk of the hypos, and one of them is hypo or hyperkalemia because it can degenerate into malignant arrhythmias. As you can see, this patient was in normal sinus rhythm. All of a sudden, something happened. This is what we call R on T phenomenon, because potassium changes the membrane potential of the cardiomyocyte, thus making it a very fertile ground for degeneration into a chaotic arrhythm like ventricular tachycardia. Finally, in the era of devices, a lot of patients have got pacemakers. You may be even told to examine a patient with a pacemaker. You touch the patient's chest. Usually it's in the left lateral region, and always look for this. This is called a spike, where my arrow is. And that brings us to the end of the session. So we have gone through a quick overview of how to approach ECG. And then we have gone through the ones which are most likely to be asked in the setting of OSCEs. Ischemias and infarction will always come. The one that they usually like asking is usually inferior ischemia. But don't forget, they can also bring inferior ischemia in a patient with also hyperkalemia. I don't know whether they will give you a brief history, but usually I remember in MCQs and in long cases, sometimes they can ask management or approach to a patient with inferior STEMI, or you'll just be given an ECG and you'll be asked question by question, what is the abnormality in this ECG? How do you approach, and so on and so forth. So always you interpret in the context or the clinical context of the patient. Remember ACS, acute coronary syndrome, you stick yourself to ST segment region, elevations in the respective leads. If you see ST segment elevation in one lead, ask yourself, what is the contiguous lead? What is the neighboring lead? And then from there, we talked about chamber enlargement, left ventricular hypertrophy, right ventricular hypertrophy. Don't forget it. They like asking it. Another important thing, sorry, I didn't post here, is PE. They may give you an ECG or a scenario of a patient who developed tachycardia, hypotension, and this is the ECG. Always look for one thing. The most important characteristic of PE is sinus tachycardia. There is nothing called pathognomonic. This thing of saying S1 QT3 is not pathognomonic for PE. It just tells you right ventricular strain, period. But the most important ECG finding is sinus tachycardia. In addition to sinus tachycardia, you may see right axis deviation. You may see features of right ventricular hypertrophy. You may see S in lead 1, which is right axis deviation, and Q3, T3, meaning Q wave in lead 3 and T wave inversion in lead 3. So PE is another possibility that they may bring. Atrial fibrillation, they may channel you to the direction of risk stratification. How do you approach? What is the most important thing you evaluate in this patient? Blah, 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 blah. When it comes to ventricular tachycardia and ventricular fibrillation, know the difference between cardioversion and defibrillation. Ventricular fibrillation, you defibrillate. If the patient has ventricular tachycardia and there is no pulse, you defibrillate, you shock. But if the patient has got pulse, but there is ventricular tachycardia, you look at the stability of the patient. If the patient is hemodynamically unstable, meaning the blood pressure is very low, the patient is confused, then you cardiovert. So cardioversion, you do it when the patient has pulse. If the patient does not have pulse, you shock, you defibrillate. And there's a way of doing it. The difference, you can see it on the machine when you're defibrillating and when you are cardioverting. So I'll rest my case here unless there is any question. I hope it was helpful. I'll share with you the slides so that you can go through if you have time.
Shukran a lot, Dr. Hassan. We really appreciate it. It was a high-yield session, and I believe we all understood and at least have a good basics for the ECG. There are some questions that have been posted in the chat, and I will read it out to you, Dr. So the first question, could you please repeat when to cardiovert and when to defibrillate for ventricular tachycardia?
Yeah, so that's what I was saying. So in cardioversion and defibrillation, the difference is when you look at the defibrillator, usually there is something called synchronization. In cardioversion, you synchronize. There's a button called synchronization where you press and you put it exactly on the QRS complex. So you defibrillate in the setting of either ventricular fibrillation, whose ECG I have shown you is very chaotic, it's irregular, it's like mtoto amechora something on a paper. When you see such a thing, it's called ventricular fibrillation, and you defibrillate. In defibrillation, you shock, you give high energy, and you don't care where it's falling in the QRS complex. While in cardioversion, you only cardiovert a patient who has ventricular tachycardia. So you will never hear me talk of cardioversion in ventricular defibrillation. They can't go together. So ventricular fibrillation, automatically you defibrillate. Ventricular tachycardia, if the patient has pulse, but is hemodynamically unstable, and here it means the blood pressure is low, the patient is confused, blah, 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 you cardiovert. But if the patient has ventricular tachycardia, but there is no pulse, we call it pulseless VTAC, then you defibrillate or you shock. So shocking and defibrillation is more or less the same. And you shock, they're called shockable rhythm. Shockable rhythms is pulseless VTAC and ventricular fibrillation. While cardioversion is done in a patient who is hemodynamically unstable but has pulse and can either have VTAC or even atrial fibrillation. Even atrial fibrillation, supraventricular tachycardia, atrial flutter, all those other arrhythmias, if the patient is hemodynamically unstable, but there is a pulse, then you cardiovert. I hope that makes the difference.
Yeah, thank you, Doc. So the next question is, what is the pathophysiology of bradycardia in inferior MI?
So that's a very good question. I don't know if you remember the anatomy, the sympathetic supply. So the SA node is the inferior part of the heart is usually very dense with parasympathetic, while the upper part of the heart is rich both in sympathetic and parasympathetic. So the AV node, and usually the predominant nerves is usually the parasympathetic. Okay, so when you have got an inferior MI, the parasympathetic system becomes even more activated. Number two, the other second reason why it's important they get bradycardia is because 60% of people's AV node is supplied by, 60% of the SA node, the population is supplied by the right coronary artery. So when you have an inferior MI, basically it's an occlusion of the right coronary artery. And therefore the SA nodal artery, which comes from the right coronary artery, is also somehow compromised. And when that happens, the parasympathetic system, which is usually the overdrive system in the heart, becomes more prominent and they get bradycardia. That is why a patient who has inferior MI can get AV block. Even they can get complete heart block. So if a patient with inferior MI comes with complete heart block, we don't usually get scared. We don't put pacemaker. We only put something called temporary pacemaker. You fix the RCA, you clean, you put a stent, and the complete heart block is reversed. But if a patient has got anterior MI and they also develop complete heart block, you put a permanent pacemaker. That's why bradycardia, complete heart block, blah, blah, blah in the inferior does not scare the cardiologist as such. What scares most is a block, complete heart block in anterior MI. Now, sorry, I take you back. There's something I forgot. When it comes to the AV block, second degree type 2 and third degree are indication for pacemaker. First degree AV block, we don't do anything. Second degree type 1, we don't do anything unless the patient is symptomatic, unless the patient has syncope. But second degree type 2 and third degree complete heart block is an indication for pacemaker. Yes.
Dr. Thank you. The other question is...
Assalamualaikum, Doc.
Alaikum salam.
Oh, sorry, I hijacked the moderator.
Yes.
Yeah, so I have multiple questions, so I don't know if the time allows you.
Yes.
So number one, just a brief summary of STEM equivalents.
Okay.
Number two, there's a new concept of occlusive myocardial infarction versus non-occlusive myocardial infarction.
Mm-hmm.
So can we basically appreciate that in an ECG in a patient who has STEMI? Can we say this is non-occlusive or occlusive?
So the first question is STEMI equivalent. STEMI equivalent are things they don't have the classic ST segment elevation, but they must be treated in terms of reperfusion therapy, what I talked about, either thrombolysis or PCI, like real ST segment elevation. And there are quite a number. One, the one I talked about, the posterior MI. In the classic ECG, you may not see ST segment elevation. You'll only see ST segment depression in V1, V2, V3. If you want to really see ST segment elevation, you put the posterior leads V7, V8, and V9. So that is one of the STEMI equivalent. Number two is left bundle branch block. That one is a bit tricky because if the patient didn't have LBB before and they come with a new LBB and chest pain, you can treat it as STEMI equivalent. But if you're not very sure, there's a criteria called Garbosa criteria, which is beyond your reach right now, but it's also considered as STEMI equivalent. Three, there's something called De Winter T waves. They usually get asymmetrical T wave inversions from lead 1, V1, V2, V3. So if you see a deep T wave inversions, V1, V2, V3, and the patient has got chest pain, and let's say troponin is elevated or not, that patient must be treated as STEMI equivalent because that usually tells you that proximal LAD obstruction. 4, there's something called the AVR syndrome. AVR is the only lead in ECG that everything is negative, the P wave, the QRS, and the T wave. So if you see ST segment elevation in AVR, it's a very, 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 very important sign. It's basically telling you left main coronary artery is also blocked. So those are some of the conditions what we call the STEMI equivalent. Now coming to the question of occlusive and non-occlusive, it's very difficult to pick on an ECG, but whenever you see ST segment elevation, you take the patient to the cath lab with a mentality that this is an occlusive coronary artery disease. There are several conditions when you take a patient to cath lab, you had ST segment elevation on the ECG, but you take them to cath lab, you do your coronary angiography, and the coronaries are very clean. In that case, now you can call it MINOCA, MI of non-obstructive coronary artery disease. They call it MINOCA, INOCA, they use different terminologies. Another good example is what I told you, it's called Takotsubo syndrome. This patient, they have a very high adrenaline surge, very, very, very high. Takotsubo has a meaning, it was discovered in Japan, but we have identified several cases. We had several cases, you are very sure this patient are going to get obstruction in LAD, LCX because there's ST segment elevation, blah, 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 blah. You do coronaries, coronaries are very clean. How do you diagnose? You do something called ventriculogram. You inject dye into the left ventricle and you can see the classic Takotsubo. Takotsubo is a special pot used in Japan for catching a certain type of fish. And it's shaped like a pot. And once you see one or two, you'll never miss it again. But the history will already tell you, is usually an elderly lady who got a very distressed call. Either she lost somebody, she got shocked, etc., chest pain. You do ECG, ST segment elevation, you do coronaries, the coronaries are clean, you do ventriculogram, and you confirm the diagnosis. So from the ECG, you may not be able to distinguish obstructive and non-obstructive. That you will only do after you have done your coronary angio.
Shukran, Dr.
Thank you, Doc. So the other question being asked by Albert is asking if you please go back to ventricular fibrillation and ventricular tachycardia. I didn't get the difference probably.
Yeah, let me see if I can share that very, very quickly. So the difference between ventricular fibrillation and ventricular tachycardia is that ventricular tachycardia is regular. Let me show you. So this is a very regular rhythm. You can see it's very clear. It's a regular rhythm. The distance between this QRS and this QRS is constant. This is constant. But this is another ventricular tachycardia. It's usually regular and well organized. But look at this. It's very irregular. It's chaotic. There are different types of graphs. One is tall, one is short. One is the distance between these two is not the same as the distance between the other. So when you see this kind of rhythm, this is a very, very dangerous rhythm. This is a patient you defibrillate, you shock. And this patient who survived this, if you have done this patient has survived, this is called secondary privation. This is a patient you put something called ICD, implantable cardiac defibrillator, so that they don't get this kind of rhythm again, because this rhythm usually kills. So that's the difference. One is regular, the other one is irregular and chaotic. Yeah.
So the other question is, Doc, so someone is asking how do you differentiate between the U wave and the Mobitz type 2?
So those ones, they don't have a relationship at all. I know what the person is asking is that, does the U wave look like a P wave? So in that context, if you are already suspecting second degree type 2 or type 1, whichever, because that's where there is usually a drop, you don't discuss it as U wave. You consider that as a P wave, because already you are dealing with an AV block. U wave usually is rarely picked in an ECG, and it's mostly picked in people who are young, healthy. or people who have hypokalemia. And by the time potassium is reaching a level where it's generating U wave, then that's a patient almost on deathbed. But I know the question the person is asking, what he means is that if you see a U wave, how will you know if it's a different P wave or U wave? And that's what I'm trying to tell you, that if it is, you are already dealing with morbid type 2 or type 1, in which case what you are seeing you consider as a P wave. You don't consider it as U wave. Because right now the important thing is to confirm the diagnosis of morbid type 2 or type 1. And the only way to distinguish between the two is the PR interval. Type 2, it's fixed. Type 1, it prolongs, then there's a drop. Then you can talk of 2 to 1, 3 to 1, depending on the number of P waves before you get another QRS. So there you don't talk of even U wave. Whatever you see, you regard it as a P wave until proven otherwise, unless you have proved that this patient has got hypokalemia.
So I think time is not on our side. The last question someone is asking, kindly repeat ECG features for PE. On
So
the
yeah,
same note, I think a question that you have already answered, kindly repeat what we do in a patient with ventricular attack and is stable hemodynamically. That one, so I think we have already discussed.
Yeah, if
so
the patient if the patient is stable hemodynamically, then you have time. Your other drugs you can give amiodarone. You can try to find out why is the patient going to ventricular tachycardia. There are a lot of things you can do if the patient is hemodynamically stable. If the patient is hemodynamically unstable, you cardiovert. If the patient is hemodynamically unstable plus there is no pulse and is VTAC, you defibrillate or you shock. Now coming to the question of PE, the most important or the most specific sign of ECG sign of PE is sinus tachycardia. All the other things we talk about are secondary. And you only look for, because PE, just think of it pathophysiologically, PE is a clot which is blocking the blood flow from the right ventricle, whether it's in the main pulmonary artery or in the branches. So when I'm the right ventricle, I am pushing blood, but there's something standing on my way, the ECG will show features of right ventricular strain. Therefore, you can have right axis deviation, you can have right atrial enlargement, you can have features of right ventricular hypertrophy, which you have already discussed. You can have the S1Q3T3 pattern, which is basically a strain pattern of the right ventricle. But the most important sign and the commonest is sinus tachycardia. So sinus tachycardia, features of right ventricular strain, S1Q3T3 are features of PE, whether it's acute or chronic. Some of those things you only see in the acute, like sinus tachycardia, but S1Q3T3 R more than S in V1, features of RVH and right atrial enlargement you see in chronic PE, or if the patient has developed pulmonary hypertension.
Okay, fine. Thank you, Dr. There might be one last question. Could you please repeat all infarct on ECG?
So the all the infarct is Q wave. Basically, you just look for a Q wave. And Q wave, I told you, is if you have got usually there are some leads, for example, I will expect them to have Q wave. Some leads, I don't expect them to have Q wave. For example, I should not, in a normal circumstance, see Q wave in V1. There should be no Q wave in V2 and V3. If you see Q wave in V1, V2, V3, that is an infarct. Because normally the way the stimulation of the heart occurs, usually you expect a small R. So instead of R, if after the Q wave is coming down, then that is like in this case. Usually there's a small notch here where my arrow is. But if you don't see that and it's coming down straight the way it's seeing here, then that's what you call a Q wave. Now, some leads can have a small Q wave, especially the lateral leads, like lead 1, AVL, V5, V6, a small lead, a small Q. But if that Q becomes very deep, in other words, it's reaching more than a third of the corresponding R wave, that's also a pathologic Q wave. So we have pathologic and non-pathologic. The small Q waves in lead 1, AVL, V5, V6 is non-pathologic and it's a common thing. But if that Q wave starts getting deeper, until so much it's very prominent, then you can start talking of Q wave. Like in this ECG on the left, on the right, sorry, where my arrow is, you can see there is Q wave in the inferior leads in V2, in lead 3 and AVF. And this is an old infarct in the inferior leads. Old does not necessarily mean it happened last year. No, it's possible that it even happened 2 days ago. So there's something called evolving MI. The first thing that happens is hyperacute T wave, followed by ST segment elevation, followed by normalization of ST segment, followed by T wave depression, ST segment depression, followed by T wave inversion, eventually Q wave development. And that can happen in a span of a day, 2 days, a week, a year. But a patient who had suffered an infarct 1 year ago, the only thing that finally remains is the Q wave. And Q wave tells you that that area is dead. Yeah.
Thank you a lot, Dr. Hassan. We really appreciate it. It was a very, very informative, very brilliant lecture. And so I think we took more than expected because I think it was very interesting and very. So at this moment, I think we will let Dr. Hassan go and we will end the session, inshallah.
Inshallah, thank you so much. And I wish you guys all the best. The important thing is just be calm. These are things you all know. Try to scan the ECG very fast. Right now we are talking ECG. I wish we had more time. We'll have discussed BGS, chest x-rays and all those things. But of course, there's no time. I wish you all the best and just be calm. Try to scan the thing very fast. Make sure you don't miss the important thing. Don't just open the ECG and say, this is MI. Just ask yourself, could there be something these guys are hiding under? Maybe the patient has got inferior MI and an AV block. Because if you say inferior MI, you get a mark. If you add AV block, you get a mark like that. So try to scan everything, just be calm, go through very fast. Always think of the differential diagnosis. If you are seeing LVH, ask yourself, what could be the cause? And it's better you mention 2 common things than mentioning 5 uncommon things. If you just say hypertension and aortic stenosis, you'll get more marks than starting with, I don't know, some weird disease. So mine is just to wish you all the best, inshallah. I'll share the slides with the guys, Kina, Jamal, and the rest. And I'll be more than happy if there's any other question you guys can ask whenever we can interact. But for the rest of the other team, I think we'll be doing, inshallah, continue with the normal ECG series we have. Assalamu alaikum and all the best, inshallah, again.
Wa alaikum salam wa rahmatullahi wa barakatuh. Thank you, Dr.
Good night to everyone.